Yeah, good evening, everybody. So, welcome to the Ortho Book Club. Really great initiative by the OrthoTV, and I'm really happy to be on the. This is the second book club for me, and I'd like to welcome first Pradeep Kothadia sir, who is president of Maharashtra Orthopaedic Association. And really thanks for his time for coming, and also like to welcome Samant sir. He's just joining in 5 minutes, and really my authors who were the backbone of this bone. I'll welcome Shivam Mehra, Nindiya Mehra, Kamal sir. Vishal was supposed to join, but some family issues is there, so he will maybe join after later. Arvind Vatkar and Bharat sir. So regarding this book, uh, Kothadia sir was really impressed. I really thanks for that, sir. For even Kothadia sir in our NMOI con was there for the launch of this book, and he was first one to buy the book. So rather than wasting further time, we'll go for the next one. Again, I thanks Ashok and Neeraj Bijlani, my both the friends, for giving us the opportunity for the launching of this book. For the sorry, not launching, but the book is already been launched. And regarding this book, this was actually the Shivam's brain, the Shivam's idea. It was in 2000 something like 19 when he was doing residence in DY Patil. So he was saying that he in Lucknow with Kamal sir sees a lot of patients of gout, and still we are following the European and the Indian not having some Indian standards. So why can't we collect some data? And one more thing which we found very interesting is that there are different communities in the India, and the gout, what you call as the proportion is very different in each community. So then that's where we started this journey in 2019. COVID, we had a little bit setback, and last 2 years really collected a good data. More than 11,000 data we have already in this book. And I think, so if I'm not wrong, Shivam, we are around more than 20,000 data at present.
Yes, absolutely, sir.
And maybe we are targeting of more than 50,000, and then we may go for ICMR. Okay, so I'll just tell you the brief of this book, and then we'll start with each authors. So regarding this, these are around 12 chapters there. A small handbook, really handy handbook, it will be really helpful. The first is introduction and gout, then the metabolism. Then Shivam will really talk on the what you call as a in Indian community is a multicentric study. And then Nindiya will talk on the we call postmenopausal gout in postmenopausal and gout in pregnancy. She has already discussed with Smruti Kale, and they both had nice discussion. And so Nindiya will be presenting. And afterwards, Arvind will be going to present on the gout in spine. Kamal sir will be going to present on the retrocalcaneal pain. And then I'll be talking on do's and don'ts and unsatisfied disease, and then Bharat sir. So moving further, as I said, this is quite a small handy book, really helpful, giving you nice insight and covering multidisciplinary disciplinaries like gynec, rheumatologist, ortho definitely, and spine also. So ये चार्ट देख के बायोकेमिस्ट्री की याद आ ही रहेगी. Okay, but then this biochemistry also is very important. That is the normal metabolism we should know. When there is a dietary purines, endogenous purines, how the metabolism occurs, and then why hyperuricemia occurs, and what is the role. These flowcharts roughly explain. I will not go in much detail. Regarding the levels, which I am sure really discuss, and where we can standardize these levels if you have a big data and approaching the ICMR, because still we are, as I said, we are following Europe and US data. And why hyperuricemia occurs, as we know, there is a high intake of purine, dietary fructose and kidney dysfunction, and other things. So regarding the second topic, I want Shivam to talk. Shivam will be talking on the topic which is, you can share the screen, Shivam.
Yes,
So
sir.
Shivam is going to talk on the different communities of the gout in India. And also he, as thoda introduction of Shivam, he is my student. The first thing I will introduce that way. Definitely has done a fellowship in the with a drawer pale, limb length correction. He has also done a fellowship in Tokyo, and he's at present consulting in the with Kamal sir in the Lucknow, and really looking forward to it. Go ahead, sure.
Thank you so much, sir. So can I just share it as soon as
Yeah, please, please.
So, as rightly said by sir, thank you so much, first of all, the Ortho TV to give us an opportunity to present this book on the Ortho TV book club. called as Gout, the Indian Scenario. As the name rightly suggests, the book named Gout, the Indian Scenario. We gave this name because the intent to write this book was all about the Indian population and the Indian communities. So, as rightly said by Sir, in 2019 there was a vision, and the vision was the brainchild to go on with the research data collection was definitely mine, but the real brainchild behind was Dr. Kamal Mehra, his vision towards the 40 years of experience which he has by seeing multiple patients every day around. So he told me once when I was a post intern, and he told me that do check that the communities of the country has different variations when we talk about gout as a disease. So we started collecting data, and with the datas, what we saw was that in from 2019 till 2023 we collected around 10,337 patients data from different communities, and from different multi-centric approach. We had data from Sachin sir, I think just to pause, I think Samant sir is here. uh, okay.
Yes, welcome, sir, and then you can continue.
Okay, Samant sir.
Good evening, sir. Good evening, sir. Okay, he's paused. No problem. Shivam, continue. In between, I'll just take him. No problem.
Yes, yes, okay. So we started collecting it multicentrically, and we were trying to find out data from the northern side as well as from Maharashtra, from PGI Chandigarh, from Kurukshetra, Punjab, and everywhere. So over a period of time, we collected the data for around 10,337 patients, and out of which we had males which were 5,986 versus females which was 4,351. As we can as we can see in the graph. With different variations of the communities, we divided the communities into the Christian, Hindu, Muslims, and Sikh. And we also saw that as to how the dietary habits were there for the patients, and as to how the lifestyle modifications, as to how whether they were a binge drinker or they were non-drinkers or they were moderate drinkers, and what was the amount of smoking habits they had. So usually we had these patients from 18. The criteria was to choose patients above 20 years to 18 years up till 65 years of age. And with that, we also saw that with the data, it found out that the mean uric acid level was the highest community, which was 6.5 milligram per. Uh, with that, the following was the Christians, and the least was found to be the Muslims, as of the data which I am presenting right now. So, with the communities, what we saw is that all these factors, which we see as the predisposing factors, like the lifestyle, the diet, as well as the drinking habits or the smoking habits, do affect. And with, as rightly said, that the West world data was very different, but now we need to get into the Indian population, as we are 150 billion people. And all the communities, because of their lifestyle habits and dietary restrictions, I think we should explore that which community should modify their lifestyles to avoid this type of disease, as it is one of the disease which can be seen in almost every family. The another topic which I want to talk about on this particular disease, as we were trying to see, is that during gout or during hyperuricemia, the application of local heat or massage, what are the effects? So usually with the data, we saw that it was not recommended, as with heat therapy, there is an increase in inflammation, there is increased pain, there is potential joint damage, as well as there is fluid accumulation. The recommendation with the data also comes out that the cold sponging and the cold therapy would be better, as the cold therapy does a little bit of vasoconstriction, it gives a hydration, and it also decreases the effects of the urate crystals at the joint. So these were the main mechanisms which we can see. Usually, as I said, that there's a vasoconstriction, there's a reduced metabolic rate, and it decreases down the acidic crystal activities. We also had a research paper on the same particular topic. We did a study for around 2,400 patients. We divided them equally, and we got them with half of them with cold fermentation and half of them with the hot fermentation. And as we can see rightly in this graphs, we found out that the cold fermentation was drastically decreasing the flare-ups, whereas hot fermentation was increasing the flare-ups, and also the patients had good response. So that's all I want to talk about these two topics here with the data which I have currently, and we are still exploring more on the particular data. And I would like to once again thank for giving me an opportunity to speak on this. Over to Sachin sir.
Thank you, Shivam. It was nice, crisp. I'd like to welcome not doctor, we can say, but she's like a doctor to us all, Nindiya Mehra, the wife of Shivam Mehra. And really, she was our backbone in this book, editing, finalizing, compiling. And she is done from the IIT Kanpur Biotechnology. And she's also heading the research in the Mehra Hospital in Lucknow. So, Nindya, take over. You can start sharing your screen and you can talk on the topic on gout in pregnancy and uric acid in menopause. Before that, Samant sir, welcome to the book club.
Welcome. Yeah.
And I really thank Samant sir to joining us, because Samant sir only forwarded this word, and Samant sir's support is really required, and really because of his support and everything, we could able to compile and finish this book, and his inputs were very valuable. Thank you, sir, again.
Thank you.
Thank you so
Over
much.
to
Shivam, excellent presentation.
Thank you so much. Thank you.
I will ask you a few questions later.
Yes, absolutely.
Okay?
Sir.
Yeah.
Yes,
Yeah.
thank you.
Yeah. India, you can go ahead.
I'll just share my screen first.
Yeah.
Yeah. So, thank you, Sachin sir, for giving the introduction, and I would like to thank OrthoTV for giving us a platform to discuss our book, and it has been an honor to actually be a part of this book. So, I would be discussing two chapters. The first one
Yeah, we
being
can't see, Nindiya, we can't see your presentation.
No problem. She'll do it. Nindya, start sharing the screen. No problem.
I am already sharing it.
Okay. Yeah, it is seen now. Perfect.
Yeah, now we can see it.
Go ahead.
Okay. So I'll be discussing two chapters. The first one being increase in the incidence of uric acid uh, post menopause. So gout is a form of inflammatory arthritis, is which is traditionally associated with men. But are you able to see my screen? I, there's
Screen,
some
but there is
issue.
some right side. Yeah.
Nindya, I think you can go on with the presentation mode so that it goes from there.
Yeah. You do the slideshow. No problem.
I'll just try.
Yeah, there's still that black part which is coming.
Probably you could de-share it and share it again.
I'll actually there's some issue.
Hey, nothing to worry. You can as we can again reshare it. So in India, we'll be speaking on the two topics like a gout in pregnancy and increase in the incidence of the gout in menopause women.
So if you see all these topics in terms of uh, like gout in spine or gout in pregnancy, these are very topics which are relevant in our clinical practice, and these pose a big question when you have a pregnant lady with gout, and if you have a patient who has a spinal problem with gout. So these are very relevant questions which are not really answered in a lot of books. So I think it is really important. This book gives you an very good Indian scenario in terms of how to treat our patients, Indian patients, with the Indian data. So I'm just sorry, I'm just waiting for India to bring up a presentation, and that's why I was just trying to fill the space in. But
Yeah.
I think it is really important to show the Indian data and treat Indian patients as Indian patients rather than copying what the Europeans or the Americans have told us and then we following them. So our patients should be treated with our data, and that will be more good for our patients in terms of responses. What do you think, Dr. Samant, about this?
Arvind, you have raised a good question. But what I want to say primarily ask Shivam. Shivam, since you are done extensive studies, okay. Can you hear, Shivam?
Yes, sir. Yes, sir. Yes,
Yeah.
I am hearing. No
So,
problem. Go ahead, sir.
currently what I have observed is a lot of female population is turning out to be increased uric acid level. That is number one. And my
Okay, sir.
second question is, at what point of uric acid levels you must start the patient on anti-uricosuric agents or whatever, whichever medicine is of our choice.
Yeah,
Shivam.
Bharat sir, can you want to take this point?
Sorry, I couldn't hear it because there was some glitch. Can you please?
Yeah, see, the question is at what level of uric acid levels when we clinically advise the patient to check for uric acid levels. Okay.
Yes,
So
sir.
when the patient comes to us after 3 days with the uric acid levels.
Yes.
Okay. So when to start the patient on anti-uricosuric agents? What is the blood levels which will suggest that we must start it on anti-uricosuric agents?
Yes, sir. So actually, right now, as with the recommendations which are there in the pathological reports, they say that it should be 5.7 or above, or for the females as well as for the males, they say that it should be above 6.7 or above. But there's a rationale. But with the studies, what we are seeing here, as with the data, and I would say that Kamal sir will tally with me with that. What we are doing right now is that patients above females above 5.1 5.2 if presenting with joint pain, specifically great toes and knee pain or something specific, we start with colchicine for 10 days, and post that we start with post 10 days we start with febuxostat or topiroxostat according to the patient's pocket or the money whichever is there.
Okay.
And for the males, we start with 6 and above. So this is actually one of the rationales which probably we are trying to change in the Indian communities, because as I hypothesize, or rather we hypothesize, is that because the data have been from the West world, and those are tall, 6 foot black, genetic race is different because there is some genetic predispositions as well, which has been seen in some of the Korean papers. What we hypothesize is that actually in India, 5 and above for females and 6 and above for males with presenting pains should be started with uric acid drugs.
Okay.
And probably for that, we are trying to increase more data from now onwards. So,
and suppose if the patient is having asymptomatic hyperuricemia, then
yes. Sir,
when will you start?
Sir, to be very frank, I have not actually thought of that particular
Bharat
part.
sir.
But what we do is that if there is an asymptomatic hyperuricemia, if, like, for example, we usually do that if there was a pre-existing gout, we tell the patient once the uric acid level comes below 4, that after 6 months, keep a check on the uric acid levels. And if there is an increase without even the pain is there, above 6, without the pain, please start febuxostat. Don't start with colchicine. We tell them to start with febuxostat if there is something like that. So we keep a
Bharat,
follow for the patient.
Shivam, we have expert here.
We
Bharat
have
sir,
any endocrinologist in the group?
Yeah, we have
very good.
rheumatologist sir, Bharat Veer sir.
Very good evening,
So,
sir. Thank you
yeah,
so much
Bharat
for asking this question.
Good evening.
Sir, in our scenario, in our setup, we try to find out the clinical picture of the patient. If the clinical picture of the patient tells you that patient is having podagra, specifically podagra, or when patient comes to rheumatologist and he or she is having significant joint pain, and it is going in more in favor of gouty arthritis, or he or she is having podagra, clinically, if we are satisfied with the thing that a patient might have gout or hyperuricemia, in spite of that, if patient doesn't have any increase in uric acid level, then we can start with the any of the hyperurate lowering drugs, and we have seen tremendous result in this also.
Another question is,
in my opinion, sir,
yeah, Kamal sir.
Kamal Mehra, in my opinion, if incidental finding of high uric acid is there, but there is no pain, no complaint, then any drug should not be given.
Exactly.
But if there is an attack of uric pain or the symptom of the uric acid, then you start the uric lowering drugs, and when the serum level goes down, then stop it, but don't sleep it. You get the uric acid done every 2 monthly. If it goes above, then you again start it. In that case, even if there is no pain, we have to start the anti-uric acid drug if there was one or two attack in the past. That is my
Yeah.
opinion.
Okay,
Exactly.
I would
I'm
like to add into this that of Dr. Kamal Mehra. I completely agree with him. But the only caveat is if the patient has asymptomatic hyperuricemia, we could always tell the patients to have those lifestyle modifications so that they could decrease their uric acid naturally rather than
Yeah,
going
yeah,
pharmaceutical.
I agree.
I want to raise one point, more point, sir. If the patient is coming to you with a clinical hyperuricemia, then there is no issue. If the patient is coming to you with asymptomatic hyperuricemia, just he got the lab report and somebody told
Yes.
us that he is having raised uric acid, then we should always wait and watch in asymptomatic hyperuricemia. We should try to find out the cause if we can, and then regular monitoring uric acid level we can see, check it, and then according to if we can rule out the cause, then it's perfectly fine, and then wait and watch will be more.
You can go for the KFT.
Yes.
yeah. My second question is, hello.
Yes, sir.
Yeah, my second question is, I had heard in one of the master series in BOS, so there three rheumatologists were there, and that time they critically commented ki don't start any medications till your uric acid level is 9. I forgot the name of that consultant practicing in Hinduja. He's a young fellow. Okay, that was question number one. Second question is, when you do uric acid level, now this is I'm not a scientist or anybody. I always advise my patients who have got uric acid of 7.4 or 8, I tell them to get it repeated without any medications after 1 week or 2 weeks. So if I tell them to get it done from some other lab, that uric acid level comes to 5.8. So one patient I got done 3 times, at least 3 patients, and their uric acid in the second report and the third report from the different labs comes to normal. In that case, what is to be done?
So in that case, I used to do a third report. Go
Yeah,
for third report.
I-
Sometime patient come with the 1.2 uric acid. 1.2. Then I say go and get the second report. And if they are different, then go for third. And whatever 2 reports say, I will agree with that.
Okay, sir. Is
Sir,
Nindiya ready?
Right.
Bharat
I
sir, you want
think
to point?
Nindiya is ready.
Say in my opinion, I'll wait for clinicals. I'll go 100% on the clinical approach, whether the patient is suffering from some hyperuricemia symptoms or not. If the patient is still having 8 or 9 uric acid, then I can again start with the medicines. But again also I'll start to find out the cause of asymptomatic hyperuricemia, whether the kidney is involved, whether other any pathology is going on, or any medication patient is having that can lead to increase.
Yeah, true. So will you start the uricosuric agents if your blood reports are 5.7, 5.8?
No, sir. I will not start. I'll wait
Exactly.
and watch and keep the monitoring level up to the every 2 months, 3 months, and I'll just ask the patient to on regular follow up and see all the symptoms. If he's having any other kind of pain or podagra or any swelling, any rash, then I'll try to fix it up.
Thank you.
Thank you, sir.
Nindiya, you can go ahead, please.
Thank you so much. I think there was some issue with the connection. So I'll start with increase in incidence of uric acid levels in gout post menopause. So gout, as we all know, is traditionally associated with men, but it is increasingly, increasing in women after menopause. So what is menopause? Menopause can be described as a progressive change from pre to post menopause. with modifications in the hormonal levels, especially estrogen and progesterone, that not only takes a toll on a woman's health by impacting the cardiovascular function, osteoporosis, and sexual dysfunction, but also affects the serum uric acid levels. So, in a normal reproductive life of a woman, there is a certain level of estrogen which declines over a period of time, which is known as the perimenopause phase. And in menopause and post menopause, there is a complete decline, and which leads, so what happens is, I'll not discuss in detail, but in our book we have given a lot of examples and a lot of case studies that have been done on post-menopausal women in different countries as well as in India, and it is a well-established fact that estrogen plays a very important role in the filtration as well as the reabsorption of uric acid. So when estrogen levels are in a normal reproductive woman, what happens is estrogen increases the glomerular filtration rate, and it reduces the reabsorption of uric acid in the renal tubules. So, but when menopause hits, there is a decline in estrogen levels, which leads to a decreased GFR and increased reabsorption, leading to hyperuricemia and the risk of gout. So now there are various risk factors for gout in postmenopausal women. These are, of course, hormonal changes, as already discussed. Then there is a decreased renal function. Weight gain is also an issue that happens post-menopause, and because of the weight gain, there could be an increase in uric acid levels. Dietary changes involve involvement of a high protein-rich diet, high purine-rich diet, and then there is decreased physical activity. Post menopause women tend to gain weight, and there is decreased physical activity, because of which there can be a rise in the uric acid levels. Other factors include metabolic syndrome, medications, and of course genetic predisposition also plays a role. Now, management and prevention of gout post menopause include dietary modifications, uh, medications. Medications such as diuretics, they actually, what happens is, these diuretics, uh, in basically they reduce the blood volume and increase the excretion. Then lifestyle changes management include weight balancing and having a balanced diet. Then monitoring and regular checkups can be, serum uric acid levels can be monitored at regular intervals for postmenopausal women. And uh, having uric acid lowering medication, maintaining a healthy weight, and physical activity is very important. So to conclude, I would just highlight that menopause can significantly increase the risk of gout in women uh, due to hormonal changes and associated factors. However, with proper lifestyle adjustments, dietary changes, and medical management, the risk and impact of gout can be effectively minimized. It is essential for postmenopausal women to work closely with their healthcare providers to monitor and manage the risk factors for gout. Now, I would continue, and I would now highlight gout in pregnancy. So, to tell all of you, gout in pregnancy is very rare. And this topic, we thought of writing this chapter because of Dr. Smriti Kale, and she's the force behind this chapter and has a major contribution in it. So, gout in pregnancy, though rare, but if it happens, can pose a lot of complications. So, I'll just in brief discuss what happens if there is a gout happens in pregnancy. So while it is typically associated with gout and kidney stones, hyperuricemia during pregnancy can result in complications for both the mother and the developing fetus. So it is very important to understand the causes, risks, and the management strategies and the potential complications of hyperuricemia to ensure maternal and fetal health. So there are various factors and causes that lead to hyperuricemia. One of the factors is preeclampsia. Preeclampsia is a persistent increase in high blood pressure, because of which it can lead to a high amount of protein in the bloodstream. and thus increased uric acid levels. Then other factors could be chronic hypertension, obesity, women who are not obese and are pregnant, that can predispose them to high levels of uric acid. Then other factors include renal dysfunction, gestational diabetes, insulin resistance, as well as diet. A high protein rich diet can also lead to hyperuricemia during pregnancy. So, what impacts this could have on pregnancy? The maternal risks include preeclampsia, potential, for acute kidney injury or worsening of chronic kidney disease, and elevated blood pressure and cardiovascular complications. Fetal risks can include fetal growth restriction because of since the placenta is the nutrients and the oxygen the fetus is deprived of. Because of that, it could lead to intrauterine growth restriction of the fetus, and this could also result in preterm birth, low birth weight, as well as increased risk of prenatal morbidity and mortality. So, although gout in pregnancy is rare, but it is very important to manage hyperuricemia in pregnancy. And the few strategies that could be followed are as for like lifestyle modifications, of course, medications mostly are contraindicated. Most of the gout medications are contraindicated in pregnancy, but there are certain antihypertensive drugs that can be used to manage blood pressure, and there are certain corticosteroids that can be used. Then monitoring and medical support. So it is very important for pregnant females to undergo monitoring of uric acid levels from time to time. And when uric acid levels are monitored, they could be easily managed. So I think this is a topic which is untouched upon, and our chapter in this book actually touches upon a very rare topic which is not discussed. So yes, continued research and better understanding of hyperuricemia's impact on pregnancy will further enhance care for this vulnerable population. Thank you.
Thank you, Nindiya, for excellent presentation and on insights on gout in pregnancy and hyperuricemia. I like to call the senior more of our editors, Kamal sir, who is practicing from more than 40 years. Kamal sir, you can share the screen. Kamal sir is practicing from last more than 44 decades in the Lucknow. He has done a fellowship in the Johnson & Johnson, and at present he is heading the Mehra Hospital. Sir, over to you, sir.
Hello,
Yes, sir. Go ahead.
good evening. Well, I am going to talk about the idiopathic retrocalcaneal pain and heel pain in gout. Well, all knows that retrocalcaneal pain or heel pain are because of the plantar fasciitis, Achilles tendinitis, heel spur, bursitis, severe disease, tarsal tunnel syndrome, stress fractures, rheumatoid arthritis, gout, and heel pad syndrome. But what are the relation of the gout in all those things? There may be, we all know the symptom of a sudden onset of pain, swelling, redness, and everything. In patient with a heel pain, when we examine the patient, the duration of the pain, onset, it is sudden or gradual, activity level and the changes, recent injury, medical history, gout, diabetes, arthritis, location and nature of the pain, sharp pain, dull pain, or burning pain. In physical examination, we inspect for the swelling, redness, and deformity, palpate the heel, tendon Achilles, and surrounding areas, and range of movement of the foot. When the symptoms are there, then we ask for whether the pain is sudden, severe redness and swelling. If it is yes, then possibility of gout is there. In morning pain or pain after rest, most probably it is plantar fasciitis pain. pain and stiffness along the Achilles tendon. It is possibility of the Achilles tendonitis and swelling and worth at the back of the heel. It may be due to possibility of bursitis, retrocalcaneal bursitis. We all know the laboratory test. I'm not going to detail. Uric acid complete count to rule out the possibility of infection, X-ray to rule out the bone changes, and ultrasound or MRI for the soft tissue involvement. Joint aspiration can be done, and as far as my 40 years of practice is concerned, I have not seen a single case of plantar fasciitis having the gout. If it is a incidental finding of raised uric acid with the plantar fasciitis, I presume that it is two pathology at a time. But the pain due to gout in the plantar fasciitis or anywhere in the palm or in the sole is not possible. It was proved by the data collection of ours. Retrocalcaneal pain can be, but it is very rare to have the retrocalcaneal pain due to gout. When it is there due to gout, then there is involvement of ankle also. If the involvement of ankle and the retrocalcaneum, then it can be due to gout with the raised uric acid. Although they are very rare, but one should not left out the gout possibility in these cases of retrocalcaneum pain and plantar fasciitis. As far as the treatment part or all knows medication, rest of the joint, hydration, dietary modification, physiotherapy, topical treatment, all goes for the treatment part. Thank you.
Thank you, sir, for your insights. Though it is a rare, but we should know and you should keep as one of the differential diagnosis.
Yes.
Yes. I'll hand over to Dr. Arvind Vatkar, who is our group as a spine surgeon. So Arvind has been with us from last 5 years. He is an associate professor in MGM. He is attached to Apollo and Fortis Hospital. And Arvind will talk on the topic on gout. Arvind, you can start sharing your screen. Arvind will talk on the gout in spine. An interesting topic.
Right. A very good evening to everyone. My name is Dr. Arvind Vatkar. So in this book, I've authored a few of the chapters. And the most important, what I have authored is a spine in gout. So if you see gout in spine, it is mostly because of a inflammation which affects the spine, causing stiffness, pain, neurological complications. And basically, we'll now try to find out what is the pathophysiology for it. Okay, so the first thing what happens in most of the gout problems, like maybe it is podagra or maybe it is shoulder pain or knee pain, it is crystal deposition. So the monosodium urate crystals, they get deposited from the blood into the joints. And the second step, what happens is it starts an inflammatory cascade releasing cytokines and TNF alpha. Later on, what happens is like especially in spine, the disc also starts degenerating because of high level of uric acid, and the comorbidities add to the party and they accelerate the degeneration and the problem occurring with the gout. Lastly, poor bone density is also seen to be caused because of gout. And because of all these things, what happens in spine is the inflammation and the crystal deposits, they cause neurological tophi. So they cause tophi, which cause neurological compression. Okay, now this compression will cause back pain and stiffness. And secondary to that, those tophi start compressing on the nerves of the spinal cord and cause radiculopathy with weakness. Now, here you can see on X-rays that these kind of erosions can happen with gout, and these are, mind you, the tophi, which are not seen on X-ray properly, but on MRI they are seen properly with gadolinium enhancement. And of course, we are going to do the blood test, which we will see hyperuricemia. But the gold standard for confirming the diagnosis of that gouty tophi compressing on the nerves is aspiration and microscopy, in which you, on under polarized light you can see those crystal shaped uric acid crystals. Now, in terms of the treatment, again the pharmacological treatment remains the mainstay, but rarely used as a surgical treatment when the patient has got radiculopathy or has significant weakness which is not getting managed with by medications. Then we might need to enter and remove the compression on the nerves, basically remove that tophi. Thank you. I think I'll keep this short and sweet and end over here. Thanks a lot.
Yeah, thank you, Arvind. So now only two talks will be remaining. I'll go very fast, and then the main topic, the Bharat sir will talk on the. Arvind, you can stop sharing your screen.
I think I stopped, right? No? Yeah, I've stopped.
Yeah. Okay, I request Bharat sir, you can start with your presentation. So regarding the Bharat sir is predominantly rheumatologist, practicing more than around, we can say, 2 decades, and he is at present practicing in Kurukshetra. And over to you, the most important topic of the gout, the medical management. So rheumatologist is there. Go ahead, sir.
Very good evening to all, respected dignitaries and all the authors. Thank you so much for inviting me in this book club. Pleasure is all mine. Special thanks to Dr. Sachin Kale, Dr. Shivam Mehra, Nindiya Mehra for giving me opportunity to be part of this book, which is truly based on a Indian scenario. The word Indian scenario is very important because we don't find any specific book on a specific topic with an Indian scenario. So I think this book is to the Indians, from the Indians, for the Indians, and it is going to be to achieve many things in terms of teaching, learning, and many things all. So let's start with my topic is regarding the management part of the treatment of the gout, all the drugs. So as we all know that gout is a disease that is frequently misdiagnosed as inflammatory arthritis, and hyperuricemia prevalence is roughly around 25%. Am I sharing the screen?
Yes, yes.
Go ahead, sir.
Okay. So I'm not able to find out my screen. Yeah, I
Make
do the
it slideshow.
Yeah, no problem.
No
Slideshow.
worries. I'll speak it out.
Yeah, go
Thing
ahead.
is, prevalence of hyperuricemia is roughly around 25% in India, and urate lowering therapy, that means the treatment we are getting for the to lowering the uric acid levels, which is definitive curative treatment, is received by only 2/3 to half of the population. So half of the population, that is gout patient. So we already we have known that there is a link between hyperuricemia, gout, and chronic kidney disease. We already established the link between hyperuricemia and cardiovascular diseases. But now these days we already have literature have found that there is a specific link, strong link already established between hyperuricemia and obstructive sleep apnea, hyperuricemia and atrial fibrillation, erectile dysfunction, venous thromboembolism, as well as in osteoporosis. Your high uric acid level can leads to are also linked to metabolic syndrome also. So now everyone can ask, what are how to plan about the treatment of the what should be the aims of treatment of Dr. Shivam? Can you share my slides?
Yes,
I'm not.
sir.
I'll stop sharing.
Yeah, just remove your share. I'll just share it. I'll just share it for you.
Yeah, I have removed.
I'll just share it for you,
So,
sir.
if this book is concerned more about Indian scenario, and we have to learn through book, and we should learn how to do. So, Dr. Shivam, just put the aims part of the management part. Yeah, just. So, I felt there are three important aims of the treatment of gout. First, we have to terminate the acute attack. Second, we should prevent reoccurrence or relapses of acute gouty attack. And third, to prevent the reverse complication of disease resulting deposition of crystals on the sites, joints, kidneys, everywhere. So if we understand these three aims, then we can start managing the drugs. If we talk about drugs, there are multiple classification giving on in the literature. If I just give the points, we should be giving classification on the base of three. First, clinical classification, in which we can say it's a acute. We have to treat acute attack or chronic attack. Second, on the basis of nature, on the basis of mechanism of action, there are multiple mechanisms of action of drugs, like inhibit uric acid and acid synthesis, increase uric acid excretion, inhibit neutrophil migration into the joint, or inhibit inflammation and pain. So on the basis of these four, we have to classify again which drug we can give. And third, the main thing is based on the nature, whether the drugs are uricosuric or uricostatic. So in multiple literatures, the authors have classified by these three mechanisms: by nature, by attack, severity of the attack, and the third is mechanism of action. So in this book, we have discussed all the things, all the mechanisms. Dr. Shivam, just next slides, if you can show. We all know the biochemistry, how the uric acid synthesis pathway done. All we can remember all the biochemistry days from our college. But if I talk about topiroxostat, this is the latest molecule. It's a highly effective selective urate lowering drug. It can work as a monotherapy, and it can work as combined therapy with any other uricosuric drug. Topiroxostat is superior hyperuricemic. Topiroxostat has a superior hyperuricemic action than febuxostat and allopurinol. And the most important part is it has better safety profile in comparison to all the urate lowering drugs. What should be the indications of having this? I've given the slide. First indication is a newly diagnosed patient with or without gout, patient not responding to convenient drugs, and patient with comorbid conditions in cardiovascular disorders and CKDs. In my field, what I found is patient as well as medicos all are very confused regarding the gout, hyperuricemia, and what drug has to be given. Depending upon various parameters, somebody is having chronic kidney disease, renal derangement, somebody is having cardiovascular failure, somebody is having hepatic derangement, somebody is having some blood dyscrasias or blood disorders. So the whole population as well as the doctors are confused to which has to be taken, which has not to be taken. And if you are giving all other drugs, then like febuxostat or colchicine or allopurinol, then on regular interval you have to go through biomedical and biochemical as well as pathological test just to see whether the RFT is still normal, liver is still normal, or it's getting deranged. So to avoiding all this safety profile, topiroxostat has the most safer option right now in comparison to all febuxostat, allopurinol, colchicine, probenecid. But I feel in my setting, as well as what I've read from the literature and from last some time, we are seeing the patients. Uh, I can, from my point of view and my practice, I can tell this positive feedback of this topiroxostat, that earlier I have to, whenever the patient was on febuxostat or allopurinol, patient usually have relapses depending upon various factors, depending upon his diet, depending upon his lifestyle modification, whether he has any number of factors. Patient again came to you for the relapses, and that relapse, that means acute attack, acute gouty arthritis, acute gouty attack. Already patient was already on these of the medications. Then we might need anti-inflammatory drugs like NSAIDs. We might need corticosteroids if the patient is having severe podagra, severe synovitis of the joint, and any other thing. But after switching to topiroxostat from these molecules, now I'm having lesser population, lesser patients with which come to me again back having acute flares. So it was again offloading the NSAID usage and offloading the corticosteroid usage also. And moreover, patients are convinced that renal as cardiac, liver toxicity is rare, or you can say less in comparison to the other molecules. But yes, hypersensitivity to topiroxostat can be there. That can possible in any of the any drug. It can lead to any hypersensitivity reaction or allergic reaction. So we should be always careful on using these drugs. We should always have around between 8 to 10 weeks. We should always go through SGPT, SGOT, or RFT, and blood parameters. We should regular monitor on this. So this is the roughly about topiroxostat. Again, this works same as a febuxostat, and but it works intracellularly and extracellularly both. So some of our mechanism of action is roughly same, and rest all the other drugs, allopurinol, probenecid, colchicine, febuxostat, all we have mentioned in our book also, contraindication as well as this thing. The main confusion is always between which has to be avoided in kidney. If the patient is having renal derangement, then allopurinol should always be avoided. First thing. If patient is having cardiac impairment or cardiac dysfunctioning is there, then febuxostat should always be avoided. Although febuxostat is roughly literature said we should monitor it for the kidney also, but we should avoid in cardiac impairment. So if cardiac involvement is there, then we should not give febuxostat. If the kidney derangement is there, we should not give allopurinol. And many a times colchicine can lead to even colchicine we should not give in renal and hepatic impairment. So slight confusion on these things, which has to be precaution, which we have to take precaution. So I just sum it up in the you can see the book, and you can see the this diagram. We have sum it up in indications, contraindication, how we can avoid it. What I like the most in this book and this chapter, that we can give the in a very simple language, we can tell the people or medicos even like myself that which drug has to be taken for which thing. If the acute attack is there, then how should we approach? If the chronic attack is there, then how should we approach? You already have discussed the diets, the modifications. So I think this book is going to help a lot youngsters, medicos, students, who specifically those who can understand the Indian gout and the Indian scenario. Because when I'm taking half a minute more, when I was presenting gout on some international level, then many of that people, they may ask the random question, and that time I didn't have any answer. Why it comes only in my data shows that it usually comes in south. The prevalence is more in North India, not in South India. I didn't have an answer at that time. Some of my consultant told me that maybe that those who have high non-vegetarian diet, they can have more. Second question, they roughly asked me that why in your data it shows that men are more prone to have prevalences in men are more to have this rather than women. Then again, that some of the communities, they male, they consume more non-veg rather than thing. Some doctors may, some consultants may have arts asked me why it is more in common in grade two only. So that time I was very young and I didn't have an answer. Some consultant examiners, they told me that those people, they walk barefoot and then they get involved this and that. I don't know the still the right answer why it involves only grade toe. Might be Shivam must be knowing the answer. And so what I feel is Western culture, European culture, they all know and they are following their ideas and their classifications. But in for Indian people, for Indian students, for my colleagues, we have to have some book like this in which we can portray our work and data so that anybody can be helpful. Thank you so much. Thank you so much, everyone, for giving me opportunity to be part of this book and this discussion. Thank you so much,
Thank
sir.
you. Thank you, Bharat sir. Actually, we thought we'll ask you a lot of questions, but most
Yeah,
of the
can I ask
questions.
questions?
Yes, sir. Please go ahead. Go
Yeah,
ahead.
Dr. Bharat, good. You highlighted few points about the anti-drugs. Two questions. One is, what is the role of steroid in acute attack? And second thing is, which NSAID you will prefer to give to reduce the pain in acute attack?
Sir, thank you so much for asking. First thing, if the patient is having synovitis in acute attack of gouty arthritis, if the patient is having synovitis, then we might need corticosteroids for that to relieve, to give the relief. But it's a short course of steroid, not for long thing. So if the patient is presenting with synovitis, we should go for to all or none phenomena. We should rule out everything, and you should go for steroid. First thing. Second thing, best drug for in NSAID to as work as anti-inflammatory in specifically in hyperuricemia works as a it is etoric oxide. From my point of view, in my practice, in my boss's practices, they already told me that etoric oxide works the better because the COX-2 inhibitor, they works like that's why etoric oxide is the choice of drug which you should be choice of drug. It has lipid it has urate lowering property also, etoric oxide. So it works agar aap if you don't prescribe any other hypouricemic drug for the this, so etoric oxide also will act as a anti hyper to lower urate therapy.
And of the steroid, which one you will prefer, methylprednisolone or deflazacort?
Sir, again, it depends on the clinical situation. If the patient is having too much of the synovitis and not only one joint, multiple joints are involved, then I can go for prednisolone, might or methylprednisolone even, but only for short case, short duration. But
Yeah,
if
yeah.
the patient is having very less synovitis, yes, synovitis is there, but less synovitis as well as only one joint or two joints are involved, then we can go for deflazacort. Deflazacort will work as wonder, no worries. But again, it depending clinical picture, it all depends on the clinically, sir.
Thank you. Thank you.
Thank you so much, sir.
Samant sir, I
Thank
would
you,
like
Bharat
to
sir.
add a small thing in this drug part, as you asked. What I practice with Dr. Kamal sir here, we 99% of the time we usually prescribe deflazacort. Rarely I have seen with him here that there is a patient who still doesn't respond with on an acute gouty attack, and that time only we change it either to methylprednisolone. Probably, I think one or two cases I would have ever seen that we have changed and increased the dose apart from the 3 days. And also, as Bharat sir was saying, one thing regarding the grade two. I would like to add on that actually in the next upcoming researches which we are doing, there is research which we are trying to get with one of the labs done, is that we're trying to get the synovial fluid examination done to see whether what's the density of a particular monosodium urate crystal. So what we hypothesize is out of that is that because of the higher density, as what we know of the monosodium urate crystals, there is a higher chance that because of the pooling of the blood on the lower lips, that could be one of the biggest reasons because of which the great toe is most commonly involved, and then the knee and the other joints. It's just a hypothesis for now, but probably let's see what comes out in the further aspects. So thank you for that.
For
Thank you,
acute
Shivam.
attack, acute attack of gout, only 120 milligram dose is sufficient.
Of which? Of heterocoxib?
Yes, sir.
Elcoxib,
Only one dose.
120 milligram of drug,
Means
not 90.
okay, but only once only, not for 10 days.
So for 5 days, he usually gives it.
For 5 days.
Okay.
Yes.
Thank you.
Sir, it may vary with the clinical presentation, I feel. In my scenario, what I learned, what I am facing, and what I am 60 milligram BD will give more effect rather than 120 single dose. Yes,
Yes,
5 days or
yes.
7 days or 10 days, it may vary according to the symptoms. Yes, but 120 mg should be given.
What I do is I give 60 milligram BD for 5 days and then OD for another 5 days. That is the way I look at it. I'm not an expert, but I'm telling you from my experience.
No, sir, experience does matter. So Shivam, can you
Yeah.
just put some light on the diet, like do's and don'ts in this little bit?
Okay, so I'll just do it.
Yeah.
Thank you so much, sir, once again for giving me the opportunity to speak on the do's and don'ts. As we see that when a patient is with hyperuricemia or gout, we always try the patients to keep themselves hydrated. We always try the patients to keep a low purine diet. And we also try to keep them to maintain a healthy weight and definitely limit alcohol. Rather, I would say it is written limit alcohol. We try to tell them to avoid it, though it is a little difficult for a chronic alcoholic person to do that, and also to monitor uric acid levels as prescribed. Now, what we practice as monitoring of the uric acid levels, what we do is that once we start with the uric acid lowering drugs like febuxostat or topiroxostat, we try to just get a repeat uric acid level done post 2 weeks, and then we keep it follow up every 1 month. And also consider coffee intake, because some of the researches which I was reading through when I was going with the book, there was a research outside India. Again, it was a South Korean paper, which I remember. It was saying that even the increase of coffee intake, because of the antioxidant properties, they decrease some uric acid levels. So that was the do's. And for the don'ts, again, it's a high protein diet which should not be taken. Uh, we should limit the sugary beverages and also avoid significant crash diet. Sometimes obese patients, they listen to the doctors and they go into a crash diet just to get weight loosen up because of the gout or maybe because of anything. Sometimes that also causes. A lot of times we've seen in our clinical practice that younger males who are gym freaks, rather I would say, they try to take a lot of protein intake for their muscle buildup, and they usually land up in hyperuric acid levels and some joint pains. Not too often, but yes, I have seen those kind of patients here with the sir at my practice. And also we are trying to tell them to avoid stress, as well as shellfish and certain fishes which are there. Not all fishes, but some fishes are there which increases the levels. Uh, for the don'ts, as I had presented, one of the don'ts is also avoid hot massage and hot fermentation. Usually, as a practice here in North, what we see is that even at a fresh injury or even at any pain, patient believed to just put on hot fermentation or to put on some turmeric and they come up here. And that is one of the biggest reasons which we see to have an acute gout attack. That patient says that we were having a pain for like 2 or 3 months, and then we did some hot fermentation since 2 or 3 days, and they usually land up as if they've just got a knee fracture or something like that. So for that, that's the clinical presentation, as Bharat sir rightly said, that synovitis kind of a feature develop into that patients, and we then start with the acute gout procedure. So that's for the do's and don'ts for me from my side.
Thank you, Shivam. So nice telling on the like what diet should be then, do's and don'ts. Also, I like to tell you why this gout is unsatisfied disease, because actually the gout is a disease of, we can say, kings like Maharaj and Nawab, and it is still unsatisfied. Can you just tell in few seconds, like 2-3 slides, why it is an unsatisfied disease?
Okay. So just change it.
And then after that, you can just summarize and then we can have few questions from Pradeep sir and Samant sir, and then we'll wind up. Okay,
Yes,
Shivam?
sir. Just a quick one. Give me a moment. I'll just share.
In the meanwhile, I would like to
Yeah, go ahead.
say like why it happens more in the first metatarsal is because studies have shown that the body temperature at the first metatarsal is really low compared to the rest of the body temperature, and that's why they have a more predisposition for the crystals to get solidified and form gouty tophi in the first metatarsal, and that causes more predisposition for podagra.
Okay.
Yeah.
Yes, absolutely, sir.
Nice input, Arvind. Okay.
Yes, sir.
Shivam, continue.
So, as we see gout, I think why I call it as an unsatisfied disease precisely, and why we also labeled this in the chapters of the book, is because I think out of 10, probably just 6 patients are there who actually comply and who actually follow up the treatment for at least 2 months to get their urate levels reduced, because of some of the other socioeconomic status or some of the other cultural beliefs, or sometimes the asymptomatic pains. They usually leave the drugs because of the compliance of the drugs to have the allopurinol. So they usually turn up again and they come back to the OPDs after 1 or 2 months. What we see is that sometimes it's a socioeconomic constraint because there are poor patients who cannot take the drugs. Yes, gout was considered to be the king's disease, but nowadays I don't think so. It's the situation. Even in the people who are at a socio-economic poor level, they also get gout as a disease. And sometimes there are some cultural beliefs and the traditional medicines, they try to avoid it. They are like that allopathic drugs, we don't want to take it, we want to go for a homeopathy or something like that. So that's one of the reasons because of which the pain do subside for the patients even at the other parts. But if they are not taking a urate lowering drugs, then it is there. And also one of the major biggest reasons is that the stress and the clinic, the I would say their professional work, when people who are working, they usually tend to forget the drugs over a period of time as soon as the asymptomatic period happens. So as rightly said, patients, in spite of sometimes patients getting their blood uric acid levels down because of the alcohol addictions, they tend to reverse back and get higher uric acid levels and get a repetitive gout attack. So that's the reason a lot of time patients who have been seen, and there are older papers of even other consultants or either other doctors or maybe yours, when we see that 6 months down the line or maybe 2 years down the line the patient is coming back to you, and their typical answer, who is actually a relapsed case, is that whether I will be able to get free from this disease or not. And that's the reason they try to hop and do a window shopping for the doctors, because they feel probably this doctor was not able to treat me right. That's the reason the disease is back. So that's the reason I've used gout, the unsatisfied disease, as one of the major reasons. And as I rightly said, that there is alcohol, one of the major causes, because with the research, when we were collecting data, there was surprisingly one more thing came out as we talk about the unsatisfied disease. I'm just trying to highlight that a lot of times we try to tell the patients to avoid alcohol and high protein rich diet. But surprisingly, when we see the bigger culprit out of it, it was always found out to be alcohol, which came out with the data as well. And I think in the future prospects, we are trying to increase more on whether which was the biggest culprit, whether alcohol or protein-rich diet. We are trying to get three group of people as a study in the future prospects. One with who's an alcoholic and non-vegetarian, one who's only a non-vegetarian, and one who's a vegetarian but has uric acid levels. So we'll probably divide these 3 patients and we'll try to monitor and try to change their dietary habits. Yes, it's a difficult compliance aspect to change and to keep a control on their diets, but
Yeah.
with these 3 groups probably we will be able to find actually that which is the biggest culprit to find out in the disease. So
Yeah,
thank you so
Shivam,
much, sir.
thank you, Shivam, for that nice explanation of unsatisfied. I think we're running a little short of, we are on short of time. So just in quick summary, and then we can take few questions.
Okay. Uh, so, so just the summary with the book. This summary is a small key takeaways from the book. I personally feel that apart from when we started this book, the all the data which I was able to find out on the PubMed, surprisingly, there was only one paper from the Belagavi Gaon, from the rural population, which was associated with CRD Pune, who had done a research on overall prevalence of hyperuricemia in the particular village. Apart from that, now we have a particular data as well as the research papers on the particular disease on PubMed as well. But I personally feel with this book, this is one of the intents to be very clear, as Vatkar sir very nicely said, that we should focus on the data from the Indian population so that we can actually deal with the Indian population and get them right. Because whatever has been done from the West, just like in every aspect, whether it's cricket, whether it's politics, we are changing, we are becoming made in India concept, we're trying to be the Indians. Probably I think we should get into the other metabolic diseases as well in the same manner, and we should change the prospects for the diseases. So yeah, that's from the summary summary for the book. So
Yeah, thank you, Shivam. Pradeep sir, any questions from your side? Sir, unmute yourself, sir. Yeah, yes, sir.
It's an excellent things which we have come to know. I read the book and some ideas still got clear to me there. I want to ask all the panelists whether we should put investigation of uric acid to each and every patient coming to you, or you would like to have some suspicion that if the patient is not responding, then you go for a uric acid level, or you should do for every patient who is coming to our OPD. So this is from me to Shivam or all the panelists, whoever is there.
Yeah, Shivam, you
And
can go ahead.
Yeah.
okay. So I think what we are practicing as a, this is a very subjective question, and thank you for asking that question. I think all of us will get educated with this question. I personally feel that when particularly on all these topics like spine and gout, as Dr. Arvind Vatkar rightly said, a lot of times we see low back patients, and which are one of the most common patients which we see, and even the rheumatologist people see around. A lot of patients who have a clear MRI, which is not a contrast MRI, and who are having a vague pain, I think we should get a uric acid level done, and not for all the patients. With the research, also, I feel that females with a menopausal age or maybe above 40 years of age, if having a knee pain, even if it's starting with 10 days or maybe 20 days or 15 days, which is the dull aching pain or a particular joint pain, even sometimes shoulder pains, we should, I think, get a uric acid level done, not the whole KFT, but just the plain uric acid level done. And also, we usually tend to avoid patients with a younger age and no diet on and no history of any high protein intake to get a uric acid level done. So I think
Shivam, I'll interrupt you here. Like what sir's question was, not all the patients, so definitely this is answer to not the all the patients, predominantly those who are having the symptoms like a knee and the great toe, like mimicking towards the gout. And all Shivam's pointed out some other features like clinical features, then only because all the patients we can't do uric acid levels.
Yeah,
Yeah.
That is.
like
Sir,
that one.
yes.
So I
And,
agree with Dr. Kale that in terms of if the patient has symptoms, there is a high degree that these patients might have gout. Okay, and it has happened like sometimes, the gout has been a very unrecognized disease for many years. And when the patient has very classical symptoms of a podagra or something like that rather than knee pain, then we actually think, okay, this could be gout. But knee pain as such, or sometimes back pain, are masqueraders in which we can find out gout. And it is, even in my practice as an spine surgeon, I do prescribe in terms of getting uric acid levels done to find out if the patient has gout. And surprisingly, I have gout. I have found out gout in a few of my patients who have got just simple back pain. So it does happen.
In my practice, I usually go for the for uric acid examination in case of osteoarthritis knee.
Okay.
Thinking of it, there may be two pathology. One is osteoarthritis, along with that gout. If we get rid of the gout pain, then what remains is because of the osteoarthritis.
Okay.
So in every case of osteoarthritis, I do have the
Uric
uric
acid
acid
level.
done.
Okay. Okay. Now this is question to Nindiya. Is there any side effects of the uricosuric drugs when you are going the pregnancy? Is there any side effects of that drug when you are using this drug in pregnancy?
So I think the clinicians will be able to tell this, answer this question better.
Okay.
But as far as
As
I
a-
have studied, there are multiple drugs which are contraindicated in pregnancy.
Yeah.
So, but I think there are certain drugs which can be used. I
Actually,
would
in
ask.
India, you actually already told in your presentations that normally most of the drugs of the gout are actually contraindicated and it should not
Yes,
be used unless they are very severe and they can refer to the rheumatologist. But most likely, as you said, it is very rare because already spoken to my counterpart and they say it's very less literature is available. The only point of highlighting this chapter on this book was because it is still an untouched topic and that's the reason
Okay.
this. So,
Okay.
sir, the reason answer to your question roughly,
In my
definitely
Yeah.
not to give any unless they are really proven and taken the opinion because most of the drugs are contraindicated in first trimester. Yeah,
Okay.
Arvind.
Okay.
It must be very rare to
Yeah,
have the
Yeah.
gout in pregnancy because whatever incidence of gout is there, that is most post-menopausal area.
absolutely.
Okay.
Once the person, our lady is pregnant, that means that she is in pre-menopausal age.
Okay. Okay.
So how can the gout is there?
Now
So basically,
the
what happens is like lot of these
hmm,
estrogen, progesterone,
Yes,
all these hormones
I
are
think
quite
I
in a
think
rage during
I think
pregnancy.
I think defect in the kidney can lead to the uric acid,
okay,
gout in these patients.
Okay. Okay.
I would like to add on it. There are certain factors that can predispose a female in pregnancy towards gout. And as rightly said, it could be kidney dysfunction, or it could be if a lady is obese, or a certain genetic disposition. These are certain factors, or a purine-rich diet during pregnancy that can all predispose a woman towards hyperuricemia and gout, although it's
yeah,
quite
Bharat
rare.
sir.
But
Bharat sir, you
I
want to
feel
add something?
we should always avoid any drug in pregnancy.
Absolutely,
Right
Yeah.
to
absolutely.
Absolutely.
yes.
Absolutely.
Okay, Bharat sir, any final take?
Thank you. No, thank you so much, sir, for
Hey,
inviting
really,
me, giving me
yeah,
chance.
actually, it was very nice, Bharat sir. They're telling a lot of things, maybe also clearing your doubts also, which is nice to tell yourself on the tell everybody that you had a doubts on this, and a lot of things were got clear by this study. Pradeep sir, final comments, and then we'll wind up.
Yeah, I think so. It's an excellent thing that in a book on the gout. I read all the book which is there. It has cleared many doubts, and I think I changed a little bit my views about the gout as well as whether the patients are coming in the OPD. I changed, included the uric acid levels, no, estimation of all the patients like that. So it's a really good thing. No, eye openers to all the people, and it is regarding the Indian. It is been studied in the Indian population. So it is really a good thing. I think it is the largest data you have collected. I think better than Western people. So I
Yes.
congratulate you all people, and especially Shivam, who has taken a lot of efforts to come out with this book, which is there. Huh?
Thank you.
Thank you.
Thank you, Pradeep sir, Kothadia sir, and thank you all of you, Kamal sir, Bharat sir, everybody, and
Yeah.
Shivam. Last take, and then we'll tell Poonam to close it.
Yeah, thank you so much, sir, for giving us an opportunity. Thank you, Ortho TV. Thank you, Pradeep, sir, for being a part and giving us so patient of your time, and that too with such a busy schedule, and Sachin sir as well. Thank you, Vatkar sir, as well as Dr. Vishal Kumar sir, who's not available with us here to be a part of this book. And I think in the future prospects, we'll try to get more and more knowledge about this, because as we've started to step into the Indian population, probably we'll make it big because we are
Yeah.
big. So that's the point I would say here.
Yeah, yeah. So
And
we
also
are
special thanks to Miss Nindiya Mehra, because she has been one of the biggest editors for the book, who has written and who's done a lot of editing for this particular book to be so crisp when we read it, and to be so easy to read it for any person who's there. So yeah, thank you so much, sir.
Thank you, Shivam. Thank you, everybody. Poonam, is Ashok or Neeraj there? Otherwise, we'll end the session.
Hi,
Yeah,
Sachin.
okay. Yes. Bolo, Ashok.
No, I went through all the discussion and it was very, very interesting. And there are so many things that we don't know. So I think this book addresses a lot of practical points and is definitely useful for orthopedic surgeons, of course, but any clinician who is treating gout and other inflammatory disorders. So congratulations to all the authors and thanks for conducting this book club. It's an excellent
Thank
meeting.
you. Thanks a lot, Dr. Ashok.
Thank Ashok and thank Neeraj, and again thanks OrthoTV for giving us the opportunity. So maybe we will try to collect more data, and we will have one more time, maybe second edition properly with the big data. Okay.
Sure. Thanks.
Thank you everybody. So we wind up
Thank you.
there.
Thank
Good
you.
night to everybody.
Good
Thank
night,
you.
sir.
Good
Good
night.
night.
Thank
Thank
you.
you.
Thank you.